The views expressed in this podcast are my own and those of my guests. They do not represent or reflect those of UCSF Health or my professional and clinical roles there. The content is intended for informational purposes only and is not medical advice. Please consult a qualified healthcare professional for specific medical guidance. In today's episode, I have the honor of sharing the microphone with one of the founders, or godfathers, if you will, of cardiac electrophysiology, Dr. Melvin Scheinman. Dr. Scheinman is originally from the Northeast, growing up in Brooklyn, New York. He was awarded a scholarship to Johns Hopkins University, where he graduated first in his class. He attended medical school at the Albert Einstein College of Medicine. His residency was completed at the University of North Carolina, Chapel Hill, and his cardiology fellowship at the University of California, San Francisco. He is probably most well known for being the first ever to perform a catheter ablation on a human in 1981 at UCSF. He was also the director of the Cardiac Arrhythmia Genomics Clinic at UCSF. References to his many incredible accomplishments and awards will be available in the show notes for today's episode. It was an honor to work with Dr. Scheinman during his last year in clinical practice at UCSF Health. He is truly one of a kind, and he is held in the highest regard by his patients and colleagues. The intent of this interview is to share with others some of the beautiful heart, pun intended, that he has for patient care. I want his patients to know they were genuinely cared for, his colleagues to know the value that they brought to him, and everyone else to know that there are, in fact, brilliant clinicians with the kindest hearts hoping to make a difference. Dr. Scheinman continues to make a difference. I know that my practice and my care for patients will always carry a piece of his influence. May we all be more like Dr. Melvin Scheinman. Dr. Scheinman, thank you so much for talking with me today. I appreciate it. So I feel very fortunate that I've got to follow some of your patients as they're transitioning to the different attendings. And the one thing that every patient has consistently told me, and their family members, is how you made them feel like they were your only patient. And as a nurse practitioner who's taking care of these patients, that is something that I would like to emulate. And I strive to have patients tell me those things or speak about me that way. And so I kind of want to know your philosophy in patient care, because I did do some reading. I read you were in the labs and you were doing the biochemistry at Johns Hopkins, and you had then decided to go to medical school. It was because you didn't want to just be in the lab, you wanted to be with people. Is that right?
Yes.
Can you tell me more about that?
Yes, I actually started my career in biochemistry. I was fortunate enough to get a scholarship to Johns Hopkins, and I had a wonderful tutor, and I was able, as an undergraduate, to be assigned to my own project in the lab. And this was a very arcane project. I had to examine this organism, Torulopus utilis, and extract an enzyme. It was very demanding, and I was there in the lab alone. And after a few months, I decided this was not for me. It's great being a basic scientist, but you have to have that special metal and enthusiasm for this sort of thing. And I knew right away this wasn't for me. And I had to tell my mentor that I decided that I wasn't going to do this anymore. And I'll never forget, he was a very, very prominent scientist. And he said to me, "You mean you want to be a pill pusher?" And he made me feel like this big. I said, yes.
That kind of leads me into another aspect that I wanted to talk about. I read somewhere where you had talked about the treatment of students in medical school and how you have a heart for teaching, and you really didn't want to follow that model, and you wanted to teach more with kindness.
Yes. In the Northeast, the New York and Boston, at the time that I went to medical school, the students were treated very poorly. There was this belief that if you made a student really miserable about some fact, they'll always remember it. But in point of fact, people learn in different ways. And some kids were so frightened and anxious they couldn't learn at all in that environment. So I had decided early on that I was never going to do that. So, for example, I'll never pick out a student in a large group and say, go up there and analyze this problem. I'll ask for volunteers, but I don't choose on, because I don't want people to be unnecessarily anxious about trying to do well in front of a large audience.
Yeah, that would be frightening.
Yeah.
Was that your experience when you were going through medical school?
Oh, yes. Oh, absolutely. It was horrific. It was funny. So they'd given me an honor, and they said, well, as part of graduation for this year, we'd like to honor you and have a special luncheon for you, but don't make any speeches. And they said it repeatedly, we don't want any speeches because there's going to be other people making speeches. I say, fine. So comes to the meeting. Well, do you have anything to say, Dr. Scheinman? And so I was totally unprepared. So I just told the truth. I said, when I look, they said to me, what are your memories of medical school? I said, oh my God, it's absolutely horrible. And they treated me so badly. And they were my professors saying, they think, oh, it wasn't that bad, So that's a recollection I have about that.
Well, I'm glad you were honest with them.
Oh, absolutely.
So you grew up in the Northeast, is that right?
Brooklyn, New York, yes.
Okay. And how big was your family?
We had 5 children. There were my 2 older sisters and then 2 brothers.
Okay. And I think if I read correctly, your sisters were nurses or teachers or?
Both are teachers.
Okay. Did your parents own a supermarket?
They owned a store in a supermarket. It was a small grocery store, yeah. Okay. And we all worked. It was tough because it was schooling and all the other activities, but we all had to work in the store, especially on the weekends.
What was your favorite part of working in the store?
There was nothing.
None of it.
There was nothing very favorite. The most favorite thing was finishing, getting out so I could play with my friends.
What did you do?
Oh, everything. We would serve the clientele and display the groceries and meats and things like that. Mm-hmm. Yeah, we did everything.
Okay. And so when you went out and you were playing with your friends and stuff, did you play baseball or what were?
Then we had stickball.
Okay.
So you had a softball and you had a stick and you made bases and you played on the streets. And we had other games, Ring Olivio and hide and seek, and it was good games.
Yeah.
We also had spin the bottle. But that was I don't know. Are you guys familiar with that? Okay, all right.
Well, yeah,
Because I didn't know, because that was like 70 years ago.
Yeah, I don't think I ever played that game. No, I know of it though.
Yeah.
What did you think you wanted to be when you grew up?
Well, my mother said that we had to be doctors. The boys had to be doctors. And in fact, each of my brothers became physicians.
Really?
Even my younger brother, who said to my mother, I'm not interested in medicine. He said, that's fine. After you finish medical school, you'll go into business, which is what he was interested in. And which is what he did, actually.
Very cool. Very cool. But did you want to be a doctor? Or was that just always where your mind was?
Yeah, I did.
So how did you end up in electrophysiology?
Well, there really was no such thing as electrophysiology when I started in medicine. It didn't develop as a full discipline until the late 70s. I got into electrophysiology through running the coronary care unit at San Francisco General Hospital. And by virtue of taking care of a lot of patients with difficult arrhythmias, I became interested in electrophysiology. And then there was a group in Staten Island who really were the pioneers, and they started these invasive recordings of His bundle. And this caused a lot of excitement. And so some of the people, some of my very good friends who were running coronary care units, they switched over into electrophysiology as the field developed.
Okay, how did you end up in San Francisco from the East Coast? I guess I should have started there.
Yeah, well, UCSF has a very renowned reputation, and one of my friends trained here and said some very nice things about it, so I decided to apply. And I basically wanted to give living in California a try. Mm-hmm. I wanted to see what it was like. And fortunately, my wife was agreeable, and we were off to California.
How did you meet your wife?
My wife lived in Queens. I was in Brooklyn. She lived in Queens, and she had a basement that she used for parties. And my brother was a friend of her friend, and I was invited to the party, and that's how we met.
Oh, wow.
It was a long time ago.
A long time ago. That's amazing. And you have kids as well, right?
Oh, yeah, sure. We have 3. Just ordinary geniuses, nothing special.
Well, coming from you, of course.
we have 3 children, and each of the 3 have 3, so we have 9 grandchildren.
Oh, wow.
Yeah.
3, that's a good number.
It's a good number.
Are they all local, or did they kind of move away? Or
my daughter lives in Manhattan Beach, which is right near Los Angeles, but the 2 boys are up north here.
That's nice. So you have some family around.
Oh, yeah, yeah.
You're a Giants fan, is that right?
Oh, yeah.
That's great. So can you tell me about some of your mentors or the people that were impactful to you?
Yeah. One of the strongest influences of my life was Dr. Louis Welt, who was a very renowned nephrologist, and he was our chief of medicine when I was at University of North Carolina in Chapel Hill. Very, very strong person. And he was not only a superb clinician, but had a renowned laboratory in basic research. He was an extraordinarily honest person, very direct, and very caring for his patients. This was the beginning of dialysis, and it was very difficult, not like what it is now. We had peritoneal dialysis. It was very painful for these people, and there was always a big philosophic conflict. You know, are we prolonging the pain? Are we doing the right thing? And each patient was a difficult decision. And I remember having chatting with him about these things. It was very interesting. He was a great man. He said he knew I had a background in religious upbringing. I went to what's called a Yeshiva, which is a religious school, and he would say to me, "Well, what's the Jewish religious philosophy about this?" You know, and it was very interesting discussing with him, because here was this great figure, and he's asking this little frightened intern, you know, what's your philosophy? What did you learn about it? It's very interesting.
So being curious, I think that's one thing that I've seen you demonstrate as well, because I've heard you talk in conferences and other things, and you always ask questions, and they come from a place of kindness, at least from what I see. And I think that maybe that's what you got out of that as well, because, you know, he was like asking you and was curious about how you felt about it. So Can you tell me more about Yeshiva and what that philosophy is?
Yeah, that's very interesting. The philosophy in terms of a dying patient is a physician need not do anything to prolong the life of a patient who's obviously dying. However, you cannot do anything to shorten the life. And the example is given, you can't take a pillow away from the patient if you know it's going to shorten the life. You're not allowed to do anything to shorten it. You don't have to do anything aggressive to prolong it if there's no hope for cure. You're not obliged to do anything. We debate this all the time. Should we intubate the patient? Should we resuscitate? You're not obligated to do that when you know the end is near. However, you can't do anything active to curtail, even to the extent of taking a pillow away. So that's the kinds of things that we used to discuss. It was really very interesting, both on a philosophic as well as a medical level.
Yeah, it sounds like it. And it sounds like a very good philosophy.
Yeah.
And that's how I would want to be treated as a patient.
Yes.
As a patient, have you ever had a medical procedure or process that affected you or how you practice?
I've had, several surgical procedures, and I had a melanoma, which was quite serious. Fortunately, it was totally removed. So I've had personal medical problems where things could have taken the wrong turn. So I've been very fortunate.
Did you learn anything from the medical care that you received or the treatment that you were provided by the physician or practitioner?
Not personally, but I think my wife died almost a year ago, and she suffered with colorectal cancer. Going through the pain and travail was quite an experience. It was a very, very tough time through my life, and I was very impressed with her caregivers to the extent that her primary oncologist actually visited her at home. And it was very caring, and because she was a special person, she gave her physicians presents, gave the kids presents for Christmas, and so she was very special to them, and they reacted in kindness, and this was very sweet.
It sounds like it. And I do remember that.
Oh, absolutely.
And I am very sorry for your loss and that you had to go through that. It sounds like she was a very generous and kind person.
She was a very good person, yeah.
I'm sorry that I didn't get to meet her.
We had 65 years together.
Wow.
Yeah.
Wow. Yeah, and the whole journey across the U.S. and then your lives here in San Francisco and all those children and grandchildren.
There's a lot.
Yeah.
A lot to be proud of.
Yeah, absolutely.
Yeah. But the family pulled together, and it was just the way she wanted it. She didn't want anything very aggressive. She wanted her family around her, and that's the way it was.
Good. Thank you for sharing all of that about your wife. I can't imagine how hard that was for you.
It was very difficult.
Especially with you being a physician yourself.
Yeah.
And then, would you feel comfortable talking about mortality?
Yes, I think you have to at the appropriate stage where it's obvious that the patient's not going to make it. This is more for oncology than us, because in our area, as you know, there are many, many things that we can offer patients, thank goodness.
Right, yeah.
But when we deal with patients who have cancer, for example, and you know that there really isn't much more to do, then it becomes very sad. The other thing that's very sad is sometimes, we had patients with who had genetic disorders like BRCA gene, and it was really really difficult, both for the physician and, of course, for the patients when they learned that their daughter or their son had come down with ovarian cancer or other things. And this was always very, very difficult for me and for the families. But try your best to lead them through and help them.
Yeah, I sometimes find when we're dealing with patients in EP that we spend a lot of time with the family explaining the procedures that they're going through or their conditions or things like that. And so that's one thing that has come through in the patients that you used to care for that have been passed on to other providers now. The entire family just talks about visits with you and how kind you were and how much you spent time explaining those things to them. And that's been something that has been impressed upon me.
Yeah. My philosophy is they're like part of my family, you know, and that's how I treat them and talk to them. And also, I don't mind joking with them, you know. I find that if you tell a joke or say something outrageous, you know, totally outrageous, and they know it, it sort of breaks the ice. And, you know, I'm not a physician, I'm your friend, and we're talking about it. And so I very much enjoyed seeing the patients, and it was hard giving it up. But with everything else going on in my life, it was time that I had to give up something that I really loved.
Yeah. So you retired from clinical practice last year, is that right?
Yeah.
Yeah. Okay.
Well, you know, if there's any change in a patient, I'm just telling you, it's not part of the interview, but I'd love to hear about it. So if someone, you know, something dramatic happened, because Ed tells me, other people tell me, and also I look at the schedule. I always look at the schedule and I see, from time to time, one of my old patients will come back and I'll visit them.
Absolutely. I will. I think the last time I saw them, I did tell you, but because I've noticed in your in basket, because I keep an eye on your in basket.
Yeah.
So if I see meds coming back, I'll check to see if they've followed up with another EP. And if they haven't, I'll get them on the schedule and that kind of thing. But I do see that other physicians will send you and just give you a little update. So
yeah, that's very helpful.
Yeah, absolutely. I think that's great because they really do miss you. I'm sure I'm going to see these patients again, and I'll bring that back to you. But they're always asking, "How's Dr. Scheinman doing? Is he still here?" I'm like, "Yes, he's still teaching. he's still giving the fellows trouble."
Yeah. I'd love to hear, you know, how people are doing. That'd be great.
I was interested in if you have any like little philosophies that you remind yourself of when you were starting your day in clinic or something, like, because for me, when I start my day in clinic, I always try to like take a cleansing breath and think about how I can best meet my patient's needs that day. Because, you know, sometimes the patients come in and they're scared, and sometimes they're worried or nervous, or they have a lot of things to talk about, and it might not be EP related even. And so I always think, how can I respect their dignity? And I try to start the day with that to make it a good clinic day. And as you know, I work very closely with Dr. Shaw. He has a couple things where one thing he always says is that we never want to make the cure worse than the disease, and that there are only two reasons that we practice medicine. One is to make a patient live longer, and the other is to make a patient feel better. If we can't do either of those, then we shouldn't do anything. So I would be very interested to hear if you have any things like that you think about or have said or that really motivate you.
Not really. I think the thing that motivates me is what we discussed before. This is my family, and I'm going to take care of you like I want my son to be taken care of, my daughter to be taken care of. And that's sort of the motivating. I want you to feel comfortable. I want to be totally honest with you. I want you to understand the limitations of what we can do. A lot of what I did was shared decision making. Mm-hmm. For example, you know, our colleagues, whenever an issue comes up, they'll share it. Mm-hmm. I don't know whether you're aware of this, but say one of us says, "Oh, I saw this interesting case. I'm not sure what to do, and what would you do?" Blah blah blah. Yeah. A lot of times, obviously, it's not a cut and dried thing. It's a shared decision, and you have to assess the risks versus benefits, and you have to bring the patient into it. So, for example, there was one patient that the group discussed who had the long QT syndrome, and the issue was, should we be very aggressive and put in a defibrillator? And the patient had done very, very well on medical therapy, and we all agreed it was inappropriate to get overly aggressive. However, I felt it was very important to sit down and tell the patient your risk of dying suddenly is very, very low, but it's not zero.
Right.
And you have to be part of that decision. Yeah. So those are the things that motivated me.
Yeah, I think that keeping patients as like your family at the front of your mind, I think that really does make a difference in how they're treated. And that's honestly how I would want to receive care.
Yeah.
That's a big part of my practice as well, because my grandmother she was a Ukrainian refugee from World War II. And she was my favorite human being. And when I was a little girl, she had a nosebleed, and it was so bad that the EMS had to come. And so when I was 7 or 8, and I was so scared because this was my person. And they told me that she had to see a cardiologist. So I was very scared of hearts, or I was like, something was going to be wrong with that. And so I like shied away from it. And she had just a hypertensive crisis, but she ended up having AFib and getting a pacemaker. And I remember she used to take her potato chips and she would wash them off because then she could have them because, no more salt. And she'd say, Nadia, I have to take my rat poison. And I was like, what? And it was her warfarin. I didn't know all of that. And then my first clinical rotation for my family nurse practitioner was in an outpatient electrophysiology clinic. And I'd almost given up that spot to someone else because I'd never really been interested in cardiology or cardiac care because I was kind of afraid of it. And I met the EP that I was working with and the other nurse practitioners, and I fell in love with it. And then it was almost like every patient that I got the honor to take care of was taking care of my Baba. And so I think it makes a big difference because
What part of the Ukraine was she from?
Both my grandparents were from the southwestern part.
Odessa?
Like Chernivtsi, I think is how it's pronounced. Yeah.
Okay.
Not a big city. There were farmers, and they actually met each other in a German work camp.
Oh my.
During the war. Yeah. They didn't know each other before, but they got sent to work camps and had false papers that said they were Polish. And that's how they got to come to the U.S. after the war.
Well, they're very fortunate they survived. They're very fortunate.
Very, very fortunate. Now, was your mother was from Poland, is that right?
My mother was from Poland, yeah. Small village.
When did she come to the U.S.?
She came around 1920, something like that.
Okay. Yeah.
Both. My father came from Berlin, and she came from Russia, but they were in the 1915, 20, something in that era.
Mm-hmm. So you have definitely seen a lot of history and life, and not only in the medical field, but in current events and the history of the world. Do you have any thoughts, or would you like to share anything about how things have changed over time?
Well, I don't want to get into politics.
That's okay. We don't have to do that.
I don't want to get into that, but I think, things have changed incredibly, just incredibly. In the past, there was a truth. There was an absolute truth. Nowadays, the truth is malleable. Mm-hmm. You have these campaigns where people just tell outright lies. It's not only the political, but you see it the internet.
Yeah. And
you see it even among some physicians. They completely abrogate their oath, and they say that vaccines are not good for you, or they cause autism and all that. And this is unbelievable. This we never had before. This was just unbelievable. And that's something that I can't get used to, because I don't know how you can have a democracy. I don't know how you can have a civilization if you don't have a desire to have the absolute truth. People get up and they make speeches and they make up total lies, and people cheer. It's bizarre. It's just totally bizarre.
And I think it gets more and more difficult with how technology changes, and like with this artificial intelligence, when you try to go look something up and you don't know if it's real or not. I don't know if you've run into that at all.
I haven't run into it personally, but yeah, it's one of the major issues for the coming generation as AI becomes more perfected.
Yeah, and as a healthcare provider, it's always important. And I'm speaking to the nurses here too, like where we get a background in research and understanding on how to appraise evidence and things like that. Like that it almost feels like it's more important to do your due diligence now and to understand what you're reading, and you're not being persuaded, like you said, by these people that will stand up and say outright lies. Like, have to actually go to the evidence and find that, so that you are providing the best care for our patients.
Yeah, and it's very sad now because patients are getting their medical information from the internet, and they come up with really bizarre things. Like I can't tell you how often patients told me, "Oh no, they're not going to take statins. Statins are terrible. They affect your muscles and ligaments," which they do, in a very, as you know, in a small percentage, but given the benefit that they have, it's just incredible. And they get their sources from the internet. Right. It's really, it's worse now. It's worse now.
Yeah. And on the statin front, like the beauty of that is that we have multiple statins to try. And at least what I've seen in practice is if a patient can't tolerate one, there are many others to try, and they oftentimes do tolerate those.
Absolutely. And so much of the time, there have been numerous studies comparing statins with placebo, and the adverse effects of statins are very, very low.
And the patients, I feel, just get so afraid because they hear that one thing that then they don't want to hear.
Exactly. And
or they don't want to try the different
The same is true of the hormones. Women have become so attuned that the estrogen products are harmful and this and that. And in fact, there are diseases where it's critical that patients use the hormones to ward off serious diseases. This is a new thing, and is something that we as professionals have to really fight. The fact that we have so much misinformation going around.
One of the things, I don't know if you ran into this, but is the anticoagulation. We have a lot of patients who want to try, they've asked for natural remedies for that, or some kind of homeopathic alternative. Yeah. And it's frustrating as a provider to know that strokes are so devastating, when if the safety profile of the DOACs now is so similar to aspirin that it's minuscule. Of course there's a risk, and we need to talk about that, but if you meet the criteria that the evidence suggests you should be anticoagulated, you should be anticoagulated. And it's a hard thing because I'll have patients who just do not want to take it. And of course that's their right, and that's shared decision making. But if it's because of something they read online by someone who, like a discussion board of people who aren't.
Yeah, they get it, TikTok, anything.
Yes.
And they get it from influences. And it's such a bizarre thing. The influencer, in order to gain more and more people, they say something outrageous, and they get a certain notoriety and more people, and I think there's some financial benefit, and so it goes on, and it's really bad.
Yeah, it is. It's a very frustrating thing. So that is something that we could have done without.
Absolutely.
As far as the field of electrophysiology is concerned, I know you still are here with us and you're teaching, and people ask your opinion all the time, I'm sure. Do you feel it's moving in the way that you thought it would?
Oh, I'm absolutely amazed at how things have progressed from the very, start where we did a few things, and now the ability to tackle the most complex of problems is simply amazing. To think that we could cure atrial fibrillation. I remember when I was in medical school, when we first learned about atrial fibrillation, we really had no idea it was so complicated. And to think that now we have a cure for this is fantastic. And one after the other, complex atrial circuits, complex ventricular circuits, we learn more. We learn how to cure them, and it's been a great source of pleasure for me to look back and say, my God, this field is incredible. The thing that I remember so much is you can do a procedure and cure a patient. So much of medicine is palliative.
Mm-hmm.
For example, someone comes in and you say, okay, I'm going to give you a pill for this. You're not really curing them. You're sort of substituting one problem for the next. But how many things do we have where you can actually cure them? And this is what struck me when we had these young kids with WPW, for example, patients with rapid tachycardias, and they were for their whole life told, you can't play soccer, you can't do this, can't do that. And then they come in, they get a procedure, and you tell them you're cured. You can do whatever you want, and the smile on their face, makes it all worthwhile. It's just a wonderful feeling where you can say you're cured. It's not a matter of I'll put a new valve in and you'll feel better, but you're cured. You're normal. Do whatever you want.
Yeah, that's an amazing
It's
thing.
an amazing story, and to be part of it has been a great sense of pride and pleasure for me.
Absolutely. Because of the work that you did that is available to patients, and that's incredible. I did want to ask you how you felt the day that you went in when you did the first ablation in 1981. What did you feel?
We were frightened out of our minds because the technique we used was very primitive. And if you know what we're going through, what you can do is take a catheter and put it in a beaker of saline and put 200 joules through it. You get an explosion.
Yeah.
And so we knew that. And we worked for about 3 years in the dog lab before we approached patients. And we took the specimens from the dog labs and sent it to the eminent pathologists of the day, Drs. Barati and Lev, and they analyzed it, and they reassured us that we weren't blowing holes in the heart, we weren't damaging the valves, and we weren't damaging the coronary arteries, and that it was safe. So it was only then that we did it in the person, and believe me, we were very, very, very frightened. I'll never forget the first person. He was a remarkable person. He was an oil refinery worker, and I didn't take the consent because I had spent so much of my life trying to develop this. I didn't think I could get a truly informed consent, so I had my colleague do it, and he spoke to the patient. He knew what I was doing, and the night before the procedure, he said, maybe you should do more dogs. And I said, no, I know I can do it in dogs. It's safe and effective, but I'm not going to do any more dogs. If he doesn't want to do it, So the day of the procedure, I didn't know. And he looked at me and he said, get on with it, Doc. He was very symptomatic. He was going into pulmonary edema with his rapid rate. He said, get on with it, Doc. And it worked out just fine.
That's amazing.
Yeah, he lived for three more years, and his rate was controlled.
How long did you continue to do that style of ablation?
That was introduced in 1981, and then in the late 80s, radio frequency energy was applied. So we used the DC shocks from 1981 to the late 80s.
Okay.
And I was very happy when radio frequency came in. I was very happy. We had a very bright biomedical tech who told us about radio frequency. He said, why don't you use radio frequency? I said, fine. So we took the RF unit, the surgeons use it, but we fibrillated a couple of dogs. We didn't know how to set the device. It would have been great if we could have learned about RF earlier. It would have saved about 10 years.
It's still amazing, though.
Yeah, it is quite amazing, yeah.
Or how long were you working on the dogs before you decided it was time to do it in humans?
We did 3 years of dog work.
Wow.
We had Dr. Rolando Gonzalez. He was a fellow from Chile, and he was responsible for all the dog work, did a lot of good work. We did the procedure, but he did the follow-up studies. We exercised the dogs and did all kinds of EKGs and what have you to monitor them. So there's a lot of work, and he deserves the credit for that.
It sounds like you all did a lot of work. And
we had Booker Pullen, who was the tech. I don't think you didn't know him, but he was a remarkable person, and he put together all the cabling and all the technical stuff, and he deserves a lot of credit as well.
Do we have a dog honorary or a statue for any of the dogs?
No.
I think we need one of those.
Well, I didn't want to tell my kids. We had a dog at home, and they were just horrified to learn that this is what Daddy was doing, working on dogs. Oh my God, it was terrible.
Oh,
so I didn't tell them about the dogs.
They had to find out later on their own.
Yeah.
I know. Well, we just appreciate the dogs helping us get this technology to patients and to be so helpful because,
Yeah.
I mean, you gave that first patient more years of life.
He had a normal life until he died of, heart failure.
Yeah, unfortunately. So you went on after that. You kind of shifted your practice into more of a genetics foundation. Is that right?
Yes. Later on, I decided to take a sabbatical year in San Diego and learn about genetics. And I felt that this was a big vacuum that we had here. And so I started the genetic arrhythmia program here, and was very fortunate to have a family that supported us. They set up the program. His wife had ARVC, arrhythmogenic right ventricular dysplasia, and he was extraordinarily generous because there was nothing, and so he funded the program. It involved geneticists setting up a clinic, setting up a support program for the patients. We used to have a program every 2 years, and it was quite remarkable seeing that grow from nothing.
It's been amazing, and we have such a good program here at UCSF.
We have
now
an excellent. Vasanth is doing a wonderful job with that. Absolutely.
I'm learning so much. It's
exciting. It's really interesting.
And just being able to help the patients.
Yeah.
That's been the most. Looking over your entire career and the things that you've done, what strikes you as the most challenging?
Well, there's no end of challenges.
I know it's a tough question.
Looking back over my career, the things that I remember most are some of the incredible things that I was fortunate enough to be around and help people. I'll never forget when I told one patient that I was going to retire. She gave me one of the most beautiful gifts. She gave me a postcard of herself and two lovely children. She said, "If not for you, none of us would have been around." And what the story was, she was a young woman and she had intractable heart failure and was actually referred to Stanford for a heart transplant. What was not appreciated was the fact that she had a rapid heart rate. And in patients, as you know, with heart failure, your heart rate goes up in order to compensate for the decreased cardiac output. And it turned out that it wasn't just the normal heart rate, it was an abnormal atrial rhythm that she had. And so we were able to locate where it was and ablate it. And then she went from somebody needing a heart transplant to perfectly normal. And so those are the things that I remember.
Yeah.
Those are the things that really say, gee, maybe I did touch somebody, because this is what you're thinking about all the time. You've worked so hard, did you really accomplish anything? Did you really do anything? And then I think of these remarkable things that I've seen, and I say, you know what? Some of the things I did were worthwhile.
Yeah, definitely. I did want to ask you about any experiences that you had that were negative that motivated you to do things differently.
The second ablation that we did was a young woman who had hypertrophic cardiomyopathy, and she died suddenly. We did the procedure, and she was okay for a couple of months, and she died suddenly. And subsequently, it was learned that with the ablation, you cured the fast heart rate, and you put a pacemaker in to maintain a normal rate. But it turns out that it was subsequently found that there are changes in the QT interval, which can be very harmful. So if the patient is accommodated to a rapid heart rate and a shorter QT, and you bring their heart rate back to normal, then the QT interval can get inappropriately long and you can have serious arrhythmias. And this was discovered later by Dr. Brugada. So then we had to shift. And after the ablation, we kept them at a faster rate for 2 weeks, and then we came back to normal. So this was important, and thing that it bothered me that something I did might have had an adverse effect. We don't know. She had hypertrophic myopathy, and as you know, they can die suddenly. But
Right.
This was the only one where we had a sudden death, and I was always concerned about that.
That is very concerning. So what I heard from that, though, is that's why we keep the rates higher.
You keep it
after
higher for a couple of weeks, and then gradually bring it back down to normal.
Okay. I knew we did that. I just didn't know why or
It was because of the QT adjustment.
Very interesting. Okay. I know I've taken up so much of your time, and we're getting there. Of course, you're an amazing electrophysiologist and physician and teacher, and are leaving such a great legacy for the rest of us to emulate and to learn from. But if you could do anything else, what do you think it would have been? If you could have made that choice to have chosen another career path, what do you think it would have been?
It would have been music. It would have been singing. I was a member of my high school choir, and I loved music. If I could do anything else, my wife thought I had a horrible voice. But anyway, I thought I was the next Caruso. But anyway, if it was anything else, it would be something musical.
Fantastic. Do you play any instruments?
I used to play a clarinet when I was a kid, but not now.
Well, you should dust one off and try again. I'll tell you a secret. I have a French horn at home. I'm not very good at it, but it's fun. Oh, well, Dr. Scheinman, I appreciate all your time. Thank you so much for
It was great fun. It was great fun.
Thank you. Thanks for tuning in to this episode of In the Loop with Naja Vlasiuk. I hope you found today's discussion insightful and empowering. Feel like diving deeper into the topics presented today? Be sure to check out the show notes for references and more helpful information. You can also visit our Substack or Instagram, Facebook, and TikTok. Remember to stay curious and stay informed. Now you're in the loop.